Gartlan for inviting me to be a speaker here today, and I want to thank you for taking the time out of your busy schedules and practices to be here. Hopefully what I offer is informative. I'm going to give you a different perspective. It's going to be more a medical, surgical perspective. As a neurosurgeon, I deal with trauma all the time, head trauma, back trauma, neck trauma, and am involved in cases that you refer personal injury, motor vehicle accident, where you're asking my opinion, was the injury as a result of the accident and what is the extent and the significance and the long-term prognosis. We all know this. This is the majority of injuries that I see, motor vehicle accidents. This is a pretty serious crash here. The patient is taken by EMS and is brought to the hospital through the emergency room and ends up like this in the trauma bay and may or may not have to go to surgery. Now that's one extreme of trauma. Okay, the other extreme is the bumper bump where 5-10 mile per hour collision where the patient is rear-ended or they hit somebody or they're T-boned, and then we have to deal with those sort of injuries too. Now it's interesting to me that actually the rate of death from motor vehicle accidents has stayed the same, but the number of injuries and the consequences of injuries have gone down. And I like to think that's due to our technology and our expertise as physicians, and also the trauma system that identifies and gets people from a trauma scene to a hospital, a trauma center, and then there's special care that intervenes to take care of that patient, give them what we can as far as trauma services, and hopefully get them through the life-threatening problems. Some other trauma-related events, slips and falls are very common. That's probably what you see the most of. We also see extremity injuries. Somebody sticks their finger in a moving machine part. They lose a hand. They get caught in their elbow, lose a finger, something like that. Also specific impact injuries. And by that I mean somebody takes a baseball bat and hits somebody else. Okay, those sort of things. Other types of injuries can be bending and lifting, workers' comp type problems where somebody is doing their job and for some reason or other, you know, they don't do the right thing or they're forced to do something they're not supposed to do and they end up injuring their back or their neck or some other part of their body. Types of injuries we're going to go over. We're going to start with head injuries, go through some of the soft tissue, explain what a concussion and contusion are, and also talk about skull and facial fractures. Skeletal injuries, cervical, thoracic, lumbar, ligamental injuries. That's a big part of motor vehicle, low impact, low deceleration motor vehicle accidents where you get the 10 to 15 to 20 mile per hour bumps, and we deal with whiplash and low back pain and those sort of things. Skeletal fractures, of course, and then spinal cord and nerve root injuries. Why don't we start with head injuries, just a little bit of anatomy. This is the brain. It's got different parts, and each part of the brain can be affected from an impact or from an injury. And it just depends on the mechanism of the injury. And what we're going to go over is the typical concussion, contusion as related to a motor vehicle accident where it's a sudden deceleration injury. The head is flipped forward, it's flipped backward, and the skull, and within the skull, which is a vault, there is the brain, and the brain is levitating on a bed of fluid, you might say, what's called cerebral spinal fluid, and it kind of sloshes forward and sloshes backwards. An analogy would be a bowl of Jell-O, where you shake the bowl and the Jell-O shakes. That's sort of, you know, the brain is not fixed to the inside of the skull, and despite misconceptions, there are bony ridges within the skull that can cause damage to the brain in particular lobes. Most common be the frontal, temporal, and occipital tips. We won't get into much about torsion injuries or shear injuries, but that's when the brain sustains a shear force. Say, for instance, somebody gets hit in the jaw and their head goes over to one area. Even though they go this way, their brain can go the other way, and it can shear their brainstem. It can shear the axons, which are the units within the brain that supply the electrical signals, and it's like snapping a rubber band. If it's stretched too much, it will snap, and sometimes you can see that on MRI. Just some signs of external facial trauma. This is to the extreme, of course, but this is what I see. Okay, if somebody's got a little laceration or something like that, I may not see them, but I see the more extreme. And this is just to show that if somebody has a loss of consciousness, they've had a traumatic brain injury. And they may not necessarily manifest with a positive scan, but they may have a concussion or they may have other symptoms. You can have lacerations, you can have fractures, nosebleeds, and stiff neck from the flicking of the head back and forth and causing the muscular spasms. Pupils, always talk about a blown pupil. Well, what that is, that's a dilated pupil, and what that means is that the brain is under pressure from whatever mass lesion within the skull. It can be a blood clot, it could be fluid, it could be even bone that's been depressed into the brain, and it compresses the third nerve and it causes the pupil on the affected side to be dilated and non-reactive. Okay, let's go over the types of injuries, and we'll start with concussion. Now, concussion is caused when the head moves forward and there's a sudden deceleration of the skull. The brain sloshes forward, it sloshes backwards, and remember I said there are bony ridges within inside the skull, and the brain is a soft tissue, possibly the consistency of toothpaste, and when it slides up against those bony ridges, they leave an indentation in the brain, and then when it slides back, it can hit other bony indentations in the skull. The most common areas for contusions are the frontal lobes, the temporal lobes, and the occipital lobes. Now, a concussion, or in the lay, get your bell rung, means that you don't have any damage, you may not have lost consciousness, but you have symptoms. And we'll go over those symptoms in just a second. Headache is very common. You can have dizziness and vertigo, nausea, vomiting, blurred vision, short-term memory loss, and balance problems. Now, the short-term memory loss is considered a cognitive deficit. And the question always arises, does the patient have a permanent injury as a result of a concussion? Well, you don't know that as long as they're symptomatic. And if they continue to have short-term memory loss, they're symptomatic and they have a cognitive deficit. The more formal testing is neuropsychological testing, where they go through a battery of tests to really measure the degree of deficit in their cognitive testing. The other symptoms usually get better, and it can usually take 3 to 4 months for the symptoms to resolve. The biggest one is headache, and then also short-term memory loss. This is a okay. Any questions on concussions? All right, we'll go on to contusions. A contusion is where you actually see damage on the brain, either by CT scan or by MRI. Same pathophysiology, same mechanism of action. The head is shot forward with an uncontrollable force and backwards, and what actually happens is you see damage to the front part of the brain and the back part of the brain. This is the temporal lobes. They can also be damaged.
Is that inflammation?
No, it's an actual bruise. It's an actual bruise. It's an impact injury to those bony ridges within inside the skull, and it's like a bruise, okay? That you would see on a soft tissue. It's like any other soft tissue injury. The thing of it is, they can be hemorrhagic, which means that they can progress and become a hematoma, or they can be so extensive to the point that you have an intracerebral hemorrhage when you have this. And sometimes they need surgery because they're causing such a mass effect that it's causing herniation or altered mental status within the patient. Did that answer your question? Okay, cerebral hematomas, this is where I really get involved in trauma. Somebody comes in, they're dying on me, they got a blood clot in their brain, they go to surgery, we try to save their life by taking the blood clot out. As you know, there are two types, epidural, subdural, based on the covering lining the brain called the dura, and the epidural is above the dura and the subdural is below the dura. The reason it's significant is because epidurals are the result of impact injuries. That is, somebody took a baseball bat and hit you in the head, or a golf ball hit you in the head, or a baseball hit you in the head. And everybody knows Lim Nelson's wife got hit in the head and then had an epidural and died, okay? And it's that transitory period where they're knocked out, they're awake, and then they have an altered mental status, and that's what an epidural causes. Now, subdural is due to the rupture of a traversing vein between the venous system in the skull and the venous system in the brain, and then you get blood clot formation that's causing compression in the brain. And it's below the dura. Now, we can see these in older patients and they not be symptomatic. The reason is because they have atrophy of their brain. As the brain ages, it loses its plasticity, which means it shrinks from the margins of the skull and actually shrivels up a little bit, depending upon the decade of life. So somebody can have an acute subdural hematoma, be totally asymptomatic, and 3 months later have a problem. And I've seen that quite a lot in people that are 70 and 80 years old. And the case is they fall, they hit their head, they're fine. 3 months later, they're in the emergency room, they got nausea, vomiting, and weakness, and you look and they have a chronic subdural hematoma, which means that the blood clot has lysed and turned into a liquid that has about the consistency of 1030 weight oil. And what you do is you drill a hole, you drain it, and they get better. The acute subdurals are usually life-threatening. And in younger people, and by that I mean somebody who's 40-ish and younger, this mass effect will cause death unless there's surgery to decompress it, because the plasticity of the brain is greater and they have more brain because they haven't gone through the atrophy. This is just a picture of a subdural here. This is what it looks like on CT. This is what it looks like on an operative case, and this is what it looks like on the illustration. This is an epidural. You can see this is more this way, as where the subdural goes more this way, okay? Convex, concave, all right? The epidural hematoma is localized to a specific area. The subdural hematoma covers the whole convexity of the brain. That's how I remember them. All right, sequelae. That's what we're interested in. What are the consequences of damaging your brain? You can have concussion symptoms, long-term memory loss. Now, there can be long-term memory problems with either an epidural or a subdural hematoma, depending upon if there's damage to the brain underneath the blood clot. The idea is that if you have a traumatic event, an acute deceleration injury, such as a high-speed motor vehicle accident, and you sustain enough head trauma to have an acute subdural hematoma that needs surgery, there is underlying brain damage. And that can be seen on MRIs, okay? Now, whether it's significant or not will dictate where the damage is, how long the blood clot's been there, and to what extent the injury to the brain overall manifests. They can have long-term cognitive disabilities, trouble thinking, trouble with mathematics, trouble with doing active daily, the activities of daily living, what we call ADLs. And this is where neuropsychological testing comes in again, because I'm not sophisticated enough to figure out if somebody can't do their math or can't remember who the president is or those sort of things, but there's a whole battery of tests where a neuropsychologist evaluates a traumatic brain injury patient and determines, okay, they've got aesthetic cognitive deficits, or they've got mechanical cognitive deficits, or they got psychomotor skill deficits, or something like that, okay? And you say, okay, who cares? Well, who cares is the patient, because if they have a job and they get fired from that job as a result of not being able to do the job, you have hard evidence that it was a result of this accident. And it's objective evidence. It's not something, it's an opinion. It's measured, they can do it, and it's reproducible. And what I usually do is I do it initially, and then I do it at 6 months, and I use it as an evaluation as to whether or not this patient's getting better with their traumatic brain injury. Is that clear? Okay. Yes, sir.
Under the ADA, when you're a doctorate, would some of these be covered under disability tax?
Well, that's a good point. Yeah, that's a good point. And actually, you know, I would think it would be a disability, because I had a patient that very happened to, and we claim she had a disability as a result of her TBI, and now she's fighting her termination. Yeah. Exactly. Yeah. Yeah, I don't know the volume of law on that, but I mean, that was something that I get involved in because, yeah, because I'm asked, is this a disability? And yes, it is. And it's objective data that I can show them that they have this dysfunction or that dysfunction, and that's why they can't do their job. All right, let's look at some CTs. Skull fractures, not hard to figure out. It's got fractures up here in the what we call the ethmoidal sinuses. This is a left-sided fracture. The convention is the scan's on the right. This is the left. What you're doing is you're looking at the patient while he's being scanned from his feet. Okay. It used to be it was turned around, but nowadays the convention is left is here, right's here. Different types of skull fractures. This is just based on the severity. Concussion, you can have a normal CT scan. You know, people say, well, how can you have a concussion in a normal CT scan? Well, remember, it's a trauma, soft tissue trauma to the brain. And it may not manifest on a CT scan, but sometimes you can see it on an MRI. You can see injuries to the axons. You can see little deficits in there that make you think, well, maybe this is a little bit more than just a concussion. You know, this person was injured a little bit more than what they're saying. But most CT scans for concussion are normal. Traumatic epidural hematoma, we can see here. This is more the inward, like we talked about, and then the subdural is more outward. Now, this is a chronic subdural hematoma. That's what I was talking about in older patients that hit their head, and this blood clot doesn't affect them right away. 3 months later, they come in, they have symptoms, and this is what we'll see. And basically, the difference between this surgery and that surgery is here we have to open up the head. Here we can do a couple burr holes and drain the fluid out. This is a contusion, and as you can see, it's kind of mincemeat, and that's exactly what happens. The brain has been bruised, and you have these bony areas here, here, and then the base of the skull there, you have other ridges that things attach to. You have the orbits, the nerves go through, the pupils go through, things like that. So it's not a flat surface, and this is a pretty significant contusion, basically involving the left part of the left lobe, the frontal lobe, and the right frontal lobe here. And there's a good chance that this person could have affect problems after this, by that being, you know, not as jovial or not as social as they used to be, to where they actually, you know, they're mean or they do things that's socially unacceptable, or they have memory problems, or they have some sort of cognitive dysfunctions where, you know, they do stuff they're not supposed to do. It's called the Phineas Gage syndrome. Now, these are usually can coalesce into a blood clot, and we call them spay hematomas, and sometimes you have to take them out because they get so big that they cause compression on the brain and threaten the patient's life. All right. Any questions about concussion, contusion? Yes, sir. I'm sorry, what? They're fine. Yeah. Yeah. Well, that's where the family comes in. You know, you talk to the family and you say, was he like this before? Or, you know, what's going on? Because a lot of times they'll have memory problems, they'll have affect problems, they'll be depressed, you know, all those sort of things. And then what I do is I send them off to a psychiatrist, because I'm not a psychiatrist, okay? Or I do neuropsychological testing to document that there's been a change in their personality or their cognitive functions or their memory. Yeah. But that's part of the rehab part of traumatic brain injury, and we send people to places where they do that sort of stuff. Because you're right, I don't do it. I mean, I take care of people acutely, and then I refer them to where they need to go as far as the chronic problems as a result of their traumatic brain injury. Okay, cervical, thoracic, lumbar, just a little bit of anatomy. Cervical, thoracic, lumbar, sacrum. This is a fancy picture to show the sensation, or what we call dermatomes. These are the nerves. All right, remember that injuries above C7 cause quadriplegia. Injuries below C7 cause paraplegia. And quadriplegia is where you're paralyzed in all 4 extremities and bowel bladder. Paraplegia is where you're paralyzed in the lower extremities and bowel bladder. Okay, let's talk about whiplash, and then we'll get into fractures and fracture dislocation. Just a little bit of cervical anatomy. This is what we call a motion segment. It's a vertebral body. You got a disc, and of course the disc and the annulus is the covering around the disc, the nucleus pulposus. Then you have another vertebral body. You have what are called facets, which are the joints that allow you to bend forward and backwards and to do torsional movements so that you don't fall apart when you bend forward, okay? It's an actual joint. It's like a thumb joint. It has a synovium and a capsule, and it can be injured, and I'm going to cover that in a little bit as to why that's important. Now, whiplash mechanism, we've already talked about that, the violent motion of the skull forward and backwards, and what we see is because people have lap belts and shoulder belts, and they have a significant posterior impact, the head is thrown forward and then it's thrown backwards, and the idea of the headrest is supposed to stop that, but of course it doesn't always stop the forward motion, and then there's a violent back motion where the headrest stops the head, okay? The whole time that's happening, the brain is sloshing forward and is sloshing backwards, okay? The other problem is when you have an acute, uncontrolled flexion extension of the neck, you're putting strain on the elements, the motion segment. There are also ligaments, and the ligaments hold everything together, and they can be damaged. Basically, whiplash is a soft tissue injury to the ligaments of the neck, what we call the interspinous ligaments, and I'll cover that here in a second. But you can see there's extreme flexion and extreme extension, and it's uncontrolled. That is, the person can't control the degree of flexion or extension. 3 types, mild, moderate, severe. Now, mild and moderate are the hard ones to kind of prove because you may not see X-ray evidence, you may not see MRI evidence, and you may not even see CT scan evidence. It's basically a clinical diagnosis, and the person, such as myself, that talks to a patient, and I kind of ask them, okay, how much impact was there? How much damage was done to your car? Did you have a shoulder belt, lap belt? You know, what hurts? I mean, they'll say, well, it was this, this, and this, and then you examine them and they don't have any neck pain. Well, they don't have whiplash, okay? Because it has to be pain from cervical axial palpation, which means you run your fingers up and down their neck, okay? And if they have pain at a spinous process interval, then that may be whiplash. Now, that can be confused with cervical muscle spasm, which is something different. That has to do with the muscles in the neck. Severe is probably the one that you can prove on X-rays. You do a flexion extension, and you can see what we say is spinous process splaying, which means that the ligament, which normally keeps the spinous processes from distracting a certain distance, there's no control. So you see a wide display of those spinous processes on flexion, and then a overcompensation with extension, and they have whiplash, documented whiplash, and an injury. Now, that's not a surgical problem. You can't sew that ligament back together and make them better and control their pain. Okay, any questions on that? So we'll go to fractures, and obviously there's a million different types of fractures based on the mechanism of injury. You can have fracture dislocations, you can have just fractures, you can have dislocation of the facets, have a unilateral facet, jump facet, you can have an anterior wedge compression fracture, you can have a body fracture, you can have pedicle fracture. You know, there's a whole slew of different fractures in the cervical spine that are evaluated when we see a patient in the emergency room and we do X-rays and then we do a CT scan. And what we're looking for is evidence of ligamental injury and evidence of bony injury. You can also have rotary subluxation in the skull on C1 and C2. I know that's a busy slide, but it sort of shows you what we have to deal with in motor vehicle accidents when we evaluate somebody for a fracture. All right, just an example of whiplash. This is what I was talking about, this interspinal ligament. Here you can see in severe whiplash it's been disrupted. Mild to moderate, mild to severe, you may not see anything. Now, sometimes you get lucky, and on MRI you can see some edema, and then you have an idea that there's been damage to these ligaments or damage to the facets. But it has to be pretty acute. I mean, pretty soon right after the accident, within about 6 to 8 hours. If you do an MRI, sometimes you can see that. Months down the line, you're not going to see it, unless you have this sort of problem here. And then this is going to be pretty obvious. That's going to be pretty obvious, because every time they move their neck, it's going to hurt. Mild to severe usually gets better, 3 to 4 months. Conservative treatment, not a surgical problem. Even total disruption may or may not get better based on how much degenerative changes they have and the severity on the mechanism of injury. They may have pain the rest of their life, and they may have underlying degenerative changes that aggravate it. Yes, sir?
That will repair itself?
No, no. This is a non-repairable problem. Yeah, it's there. All right, compression fracture, fracture dislocation. This patient's paralyzed, and is probably going to be on a ventilator because you're around C4, and there's probably a good chance that they're going to be a quadriplegic and ventilator dependent. This is an anterior wedge compression fracture with a little bit of chip off here and posterior displacement. Now, the other problem with these fractures is you have the spinal cord running here, and we're going to talk about that too, but not only with the fracture, but you have to worry about spinal cord injuries. And that's why EMS takes great care to put collars on patients and to put them on boards and to bring them in, and they're treated with spinal precautions until we rule out injuries. So that's the reason. Okay, you may have a fracture and no spinal cord injury, but you can sure turn this into a spinal cord injury real fast, you know, if you don't know what you're doing and people start cranking their necks and boom, before you know it, they're paralyzed. All right, this is what I was talking about. Myelopathy is a spinal cord injury. Radiculopathy is a nerve root injury. Quadriplegia, bowel bladder, quadriparesis. Now the difference between plegia and paresis is plegia is motor is completely out, paresis is motor is weak. There's a five scale for measuring motor, 1, 2, 3, 4, 5. 5 is normal. 1 is you can flick the toe or flick your finger. Okay, and then I'm not going to bore you with the scale in between, but it has to do with resistance and also has to do with motion related to gravity. The reason I mention that is because I have had episodes where people have had underlying degenerative changes and spinal stenosis in the cervical area. They were in a motor vehicle accident, and then afterwards they were myelopathic. And the question is, did the myelopathy come as a result of the underlying degenerative changes? Well, it may have at some point, but the accident brought out those symptoms. The underlying degenerative changes were there, but the myelopathy was a result of the accident. Radiculopathy is an injury to a nerve root. That can be stretching of the nerve root, or it could be actual compressive lesion of the nerve root where you have a piece of bone that impacts on the nerve, you have a disc that impacts on the nerve, or you have a facet dislocation where the tunnel that the nerve's going through has been narrow because the vertebral bodies have been dislocated and they're putting pressure on the nerve root. Weakness, pain, loss of reflexes, and numbness, tingling. Those are all things that you can see. The biggest thing is pain. Somebody come in and say they have shooting pain down their arm or shooting pain down their leg. That's what we consider part of a radiculopathy. The other parts are loss of reflexes, numbness, tingling, motor weakness. Treatment, sometimes it needs surgery. A lot of times we do conservative treatments. This is a halo. That's for a cervical fracture. They may not necessarily need surgery. Usually in older patients, they may not be the best medical candidates, and so we have to treat them with something, so we put them in a halo. This is a Miami J collar. It's a hard collar. Whenever you're treating neck injuries, you need to use a hard collar. And sometimes it takes surgery. And this is for fun. This is for you guys. It absolutely does nothing for cervical injuries. It's what we call the lawyer's collar. Okay, it's what you use in court, but it doesn't mean anything. And I see a patient walking in with that. It's like, my first question is, okay, are you involved in a lawsuit? I'm serious. This does nothing but keep your neck warm. It looks good on Perry Mason. It looks good on Boston Legal, but it has absolutely no value in the treatment of neck pain or neck injuries. And people said neurosurgeons don't have a sense of humor. All right, we're going to go on with thoracic spine. Same thing, anatomy. Fracture, dislocation. Remember, the spinal cord ends in the upper lumbar, lower thoracic area. So any injuries to the thoracic spine will cause paraplegia, paraparesis, and bowel bladder. Okay? The thing about the thoracic spine, it's a little bit different than cervical and lumbar because you have an auxiliary support, the rib cage. So it tends to take a lot of trauma to do a fracture dislocation to the thoracic spine. It can be done. I've seen plenty of it, but it's a little bit harder because the rib cage needs to stabilize the thoracic spine. This is a compression fracture. We see that a lot of times when people fall or they jump and they land on their feet and they have an acute flexion of their back, and basically it's like crunching an apple. Now, there are varying degrees of this. It can be anywhere from 10% to 100%, and we usually use about 50% as the unstable guide. If it's more than 50%, it's unstable, and sometimes we have to treat that with surgery. Sometimes the problem is, too, this superior articulating surface is fractured and retrogrades posteriorly and compresses the spinal cord and causes paralysis. Just a little review. Remember, above the cervical spine, quadriplegia. Below the cervical spine, paraplegia. All right. Any questions about that? Okay. We'll go on to lumbar spine real quick. A little bit of anatomy. Cauda equina. You can see most commonly the cauda equina, which is the distal part of the spinal cord, and the conus cauda equina, ends at about L2. The conus is the distal part of the spinal cord. The cauda equina are the nerve roots that come off this. And this is an important area because this is where a lot of these axial compression flexion injuries come from. Somebody's in their car, they have a lap belt on, and they go forward and they hit their head. They can sustain an L1, L2 compression fracture, and it can cause paralysis and bowel bladder problems. Down here, a lot of these fractures, dislocations will cause nerve root problems. They may not necessarily cause bowel bladder or cause leg weakness bilaterally, but they may affect one leg or the other, and they may have radicular symptoms where they say they have pain going down their leg into their foot, or they have pain going down both legs. This is just the motion segment. You can see the vertebral body, the disc, another vertebral body, the spinal cord here, so they must be up here, and then the nerve roots as they come off, and the facets in the back. Now, this is a good example of an injury to the cauda equina. This is an anterior wedge compression fracture with a retropulse fragment. This person's conus cauda equina ended right here, and so this is probably like T12, L1, L2, somewhere around there, and this person would present with paraparesis or paraplegia and bowel bladder dysfunction. And the difference is the size of the canal. If somebody has underlying stenosis, say they're older, then they may have more severe consequences as a result of this fragment versus a younger person who doesn't have any associated central stenosis. And I've seen all kinds of this. I had a guy who fell down an elevator shaft. Young guy, is about 45, had really bad stenosis, had a fracture at L2 with a retropulse. He was paralyzed. Had an older guy, had no stenosis, same deal, and he was intact. You know, go figure. But it has to do with the underlying anatomy. This is what we call a chance or seatbelt fracture, and once again, that's that acute flexion type injury where, because you have a lap belt on, maybe not so more nowadays, but 10 years ago when there weren't so many shoulder belts but more lap belts, they have an acute flexion, and what they do is they put unnecessary forces on this area here, which is the pedicle and the spinous processes and the what we call the pars interarticularis, that causes a fracture. This is anterior wedge compression, and you can see this looks like a wedge because there's been compression of the anterior part of the L1 vertebral body with a retropulse fragment. This is a nerve root compression. Sometimes you see a herniated disc as a result of trauma, and this is what it looks like. The disc herniates and it causes compression on the nerve root. This is what it looks like on an MRI. All right, now, say we don't see those extremes. Somebody comes to my office, they say, Doc, I got back pain, I was in this fender bender, you know, what's going on? There's a phenomenon called a facet syndrome. Has nothing to do with the muscles, has nothing to do with tension or spasms or nothing, but it's an actual injury to the joint in the back that's called a facet. And remember, we talked about facets being like the thumb. They have a capsule, they have a synovium, they're an actual joint, and when they're stressed or injured, you actually get rupture of that surrounding capsule, and when it heals by scarring. So whenever the person bends forward or does a torsion or twisting motion, they put pressure on that scar and it causes back pain. You also see this in bending and lifting injuries. Somebody at work, they don't have their back brace on, they do something they're not supposed to. You know, they say, Doc, you know, I bent forward and then I couldn't straighten up. This is usually what the problem is. Now, the thing of it is, this doesn't work with epidurals. You can't treat this with an epidural injection. You have to do a facet block. A lot of doctors, a lot of pain centers don't understand that. And they keep treating these people with epidural injections, and the patient says, well, I don't get better. Well, it's because you're getting the wrong shot for the wrong problem. Okay? An epidural injection puts steroid medicine on an inflamed nerve. A facet block blocks the nerve that goes to the joint. It's like numbing up your teeth to do tooth work. So, you know, if you're trying to treat one with the other, then of course it's not going to work, okay? And that's why facet blocks also have a very bad name, because you got a lot of doctors who don't know how to do them. You can have cervical spine facet problems. You can have lumbar spine. The majority of the ones I see are lumbar spine. And it's usually related to either motor vehicle accident or bending, lifting. And this is the facet joint. And you can see right here, it's got a covering. And that covering is ripped. What this is a biomechanical system, and you overload the system, and the system fails. And as a consequence of that failure, you have ripping of tissue, and then it heals by scarring. And then whenever they put pressure on the system, it's going to cause pain. Treatments, again, sometimes surgery, and immobilization, pain management, conservative management. Okay, finally, a legal relevant point. As your healthcare provider, evaluating your client, what is my job? Well, my job is to make sure, in my opinion, that the injuries and the damage done to your client are within the risk-producing behavior of the defendant, right? I mean, that's your case. And if I can't prove that, there's no sense you taking the case or doing the case, because there's no causation. And that's where there's a lot of confusion about underlying degenerative changes. You know, I have it all the time. People come in and they say, well, I've got disc bulges or I've got arthritis or stuff like that. It's like, yeah, so what? You know, the accident didn't cause that, okay? So, you know, I take a good history from people. If it's a work-related injury, I actually have them show me how they were injured. Okay, what were you doing and what happened at the time and when do you think you were injured? I ask them about the police report for motor vehicle accidents. How much damage was done to your car? You know, did you T-bone somebody? Did somebody hit you, or did you hit them? Or, you know, try to, because to understand the biomechanics of the injuries, you have to understand the forces in play and what happened. And if I can't answer the question, you know, for your case, then I'm going to tell you, you know, there's no injury, this doesn't make sense, something happened other than, you know, what the patient or the person is trying to tell me. Does that make sense? Yeah, so in that way, that I see that as my obligation to you, that if you send me somebody to evaluate, you know, it's my job to figure out, okay, was their injury the result of what they're saying and what happened? Any questions? Okay, thank you.
Well, my name is Lynn Suggs. I'm a PhD in psychology. I have a business here in Dothan, Alabama called Professional Counseling and Consulting Services. We're located at 256 Honeysuckle at Brightleaf Court, Unit 20, and we basically do all sorts of different type of therapy, counseling, consulting, drug, alcohol, different types of things that you would have issues with. And my discussion today, and I know it's been a long day and a long afternoon, and I'm going to try and make it as easy and quick and painless, not like the last guy who made me hurt when showing me his pictures. So I hope mine's a little bit more not entertaining, but enlightening to you as to regarding personal injury, what mental health or emotional health impacts are and how that happens. So my discussion is going to be centered around more about what happens to our clients, and I'm using ours as a blanket here, as to show you what happens to them and how they feel and what they think when they have a personal injury happen to them. So have you ever thought about, and I know if this is hard for me to say, but when you think about it, what we all are today is a direct result of where we were when we received our gut level programming. Some of you may have heard that before. I wish I could tell you who quoted it initially, but I don't know. But what we each are is a result of something that's happened to us all along our childhood. And I know you're sitting there saying,